Okay, pain, our description of pain is the following. It's totally subjective. It is whatever the person experiencing it says it is, existing whenever he or she says it does. Any question about that? Do you have any problems with that definition? Okay. Most nurses I work with still have a problem with this definition, meaning they still say, oh, I don't think this patient's in pain. Okay, they're playing me. Right? They're playing, they're here to just seek drugs, etc. Based on this definition, is that true? No. Do you have proof that they're faking it? No, because this is very subjective, doesn't it? All right, so that is the nursing definition of pain. Now, if a doctor does the same, I don't know what the doctor's definition of pain is, but I know what nurse's definition of pain is or should be. Are we clear? All right, so is it our place to ask the patient to prove it? Prove to me that you have pain. Can we take their vital signs and then use the vital signs as proof that they have or do not have pain? No. Look at the next statement. Patient self-report is the standard. What is the standard? Patient self-report. All right, so no matter what your opinion is, keep it to yourself. All right, that's where it belongs. Has no room in treating pain. Are we clear? All right. So therefore, the patient self-report is considered to be the most reliable indicator of pain and the most essential component of pain assessment. What if your patient is unconscious? Does that mean they have no pain? They can't report it. What if the patient's nonverbal? Say has autism, cognitively impaired, sedated. Screw them then. Yeah, they're up the creek. No, we have different methods of pain assessment. Okay, so not just the numeric. All right, effects of pain. I don't have to tell you this, but sometimes I do. Okay, we don't really appreciate the effects of pain until we ourselves experience it. Now, pain is, especially chronic pain, can be debilitating. This can be disabling. Patients can be disabled because of chronic pain. It has effects beyond the physical area where the patient experiences the pain. So this affects the entire body, not just physically, but also psychologically, right? And chronic pain actually has devastating effects on body systems, namely the heart, the lungs, even the skin. Because what's the effect if you have pain? Are you free to move about and ambulate? Are you going to be a productive member of society? Okay. Some pain different depends also on the patient's tolerance. Some patients have very high tolerance for pain. Let's say take my wife, for example. She had 4 C-sections. After the first C-section, she just received 1 Percocet and then she didn't like it. She never took any since then, right? I don't know how it is to have a C-section, but I know I will be in pain. I mean, I had a minor procedure. I was in pain, right? Um, so differences, okay, in people's tolerance and now how they handle pain. Some people are expressive, some are not expressive. Like in my family, it's taboo to be crying about pain. Okay, I saw firsthand when I was in pain one time. I ended up in the ER. My brother was working there, and then he just stared at me. He just said, he let me know that you're an embarrassment. Why are you here? Right? And then sent me home. Right? Yeah, because it's not acceptable in my family to be like that. Right?
Wow.
Now he was a doctor. Was because we lost him. Okay. Anyway, so there are many categories of pain. We have acute and chronic. We also have different categories according to the characteristic of the pain. So acute pain also has, besides the the severity of acute pain, it also has certain characteristics, certain descriptions. Okay, chronic persistent pain is can be cancer pain, although the WHO classified cancer pain as a third category. So they put their acute, chronic, and then cancer pain was actually placed separately in a different category by the WHO. So here are examples of chronic pain. We have acute pain. So examples are, a toothache, for instance, or after acute surgery, something short term. Okay, generally speaking, acute pain is usually short term. Okay, like the examples I gave. Chronic pain, definitely, this is for chronic diseases like arthritis, for instance. However, we also have something called breakthrough pain, meaning breakthrough pain or BTP exists only in chronic pain, meaning on top of the chronic pain they experience that they're constantly experiencing, they can have acute pain on top of chronic pain. And because it's a different type of pain, the usual pain medication they take, which is usually long-acting or extended release forms of opioids, do not work on acute pain. Because again, those extended release forms are only for chronic pain. If they experience breakthrough pain, which is pain in between chronic pain episodes, that should be treated with acute pain interventions. Are we clear? Right? So you can't say, oh, someone who's, let's say, on um, who has cancer and they're taking 30 milligrams of MS-Contin ER, which is extended release morphine. You can't say, oh, when they're complaining of pain, hey, can you give me something for this? I'm in pain. You can't tell them, you're already on 30 milligrams MS-Contin. Okay, you have to wait until the next one is due, right? So that's not correct because this is acute pain. Okay, so the chronic pain that they usually have, we can't use the same treatment for that breakthrough pain. Are we clear? Right. Okay. Pain according to pathology. Pathology meaning the cause of the pain can be nociceptive. This is usually somatic in nature, meaning physical. Okay, there's a physical cause of the pain. So let's say a surgical incision, a bruise, for instance. Okay, any trauma or any organ damage, for instance. So that is nociceptive. Okay, meaning there are direct causes of the pain, meaning you can see it, there's evidence of it, there's a scan, or there's a tumor, for instance, in your skull, there's a tumor in your abdomen, for instance. So there's a reason for the pain, or there's physical evidence of the injury. However, for neuropathic pain, this is different. This is because of abnormal sensory input. Example for this is, let's say, phantom limb pain. We heard of that in fundamentals, right? People who lost their right leg continue to complain of pain on the right foot. Okay, what right foot? There is no right foot. Okay, so those are examples of neuropathic pain. Another is nerve pain, those experienced by diabetics, for instance. Okay, diabetics have nerve damage, and then that can result in neuropathy. Okay, so that's another example. Because they have different pathologies, meaning different causes, they cannot be treated with the same set of medications. So neuropathic pain will benefit best from non-opioids. Okay, we'll discuss those interventions shortly. So these are the effects. I'm not really testing table 9-1, but it's good to know. Okay, this is just a nice to know. Look at the systemic effects. So from endocrine to metabolic, cardiovascular, respiratory, genitourinary, it's a full body effect, right? Not to mention, again, it decreases mobility. So therefore patients forced to stay in bed or in the chair, and there will be complications related to immobility as well. So is it important to relieve pain? Yes. And it's also not true that the elderly naturally will experience pain. Okay, so pain is never okay. Okay, pain should be treated. either pharmacologically or non-pharmacologically. So when old people specifically say, oh, this is all just part of aging, okay, I'll have pain in my joints. Oh, of course, you need to relieve that, okay, either with compresses, for instance, or if they don't work, then you have to take pills, okay? Again, each his own though. We can't force anything on the patient. So here are examples, okay? So we have table 9-2. Nociceptive, neuropathic, and mixed pain, and you have examples here. So on a test question, when I give you the scenario, this will help you identify, oh, what type of pain is this patient experiencing, right? That would be, of course, a lower level question. This is just simply identifying what type of pain the patient has according to pathology. Any question about this table? All right. So the examples are here. So these are the examples I'll use on the scenario on the test question. Probably get 1 or 2 questions on this table. And you have the treatments here. So let's say I go beyond identification. So let's say I'll go, okay, the patient has a history of below the knee amputation. The patient describes pain as blah, blah, blah. So I'll go, based on this type of pain, which intervention would work best for this patient? So I'm asking you 2 things. You have to identify what type of pain it is and then choose the intervention. Does that make sense? All right. So of course your answer would be on the last row. So what medications are used to treat neuropathic pain? Yeah. Antidepressants, anticonvulsants, local anesthetics. All right. Do you understand? Okay. Because these are called co-analgesics, also called adjuvant drugs. Adjuvants are technically not for pain. I mean, antidepressants, are they for pain, really? Did the pharmaceutical company design this drug to treat pain? No, this is for depression. This one's for seizures, right? So therefore, these are not your usual pain relievers, okay? Because again, the nature of neuropathic pain is because of abnormal sensory input. Doctors discovered and research proved that these drugs work best for those types of pain, right? So let's say you don't wonder, patient has, let's say diabetes and complaining of neuropathy, and then they're prescribed gabapentin. Gabapentin is a seizure medication. If you look at the drug book, it belongs under seizure medications, but it's used for neuropathic pain. Okay, doesn't mean the patient has seizures. Are we clear? The next 4 items are the processes by which, how do you actually experience pain? They're not testable. Again, they're nice to know though. For instance, transduction is the process by which noxious stimuli, so let's say this one, for instance, an incision or a trauma or a burn, for instance, activate the neurons. Okay, so the activation of these neurons is called transduction. Okay. And then the next step after transduction is transmission. So how is pain transmitted? How do I know this is painful when I put this over a flame, over fire? How do I know it is painful? Okay, it has to be transmitted. So after transduction, let's say I burn my tissue, right? Because I put it over the fire. So now the transmission transmits the painful stimulus to my brain. That's the transmission. Of course, all transmission travel through your spinal cord, correct? Right, and then the next step, of course, is perception. Then the brain interprets that. Ooh, that's painful. And then what's the next step? Modulation. What is my action, therefore? If I feel this is hot, oh, it's hot, what do I do? Okay, modulation will be I do something about it. Okay, so I remove my hand from the fire. Now, another example is, let's say, what was the last time you hit your shin on something? On a coffee table or the corner? What happened? So first you hit your shin, one of the most painful things to happen. Yeah. And then what's the first step again? Transduction, right? So transduction. So there was substances released by the injured parts of your shin, and then there was transmission, correct? And then and then it was perceived that, ow, and then what is your modulation? What is a common thing you do when you hit your shin? What do you do? Tell me you never do that. Okay, and then the pain goes away, yeah? So what exactly did that modulation do? How come this thing takes the pain away? Right? How come? Right. So going back to the shin example. So part of the modulation is, let's go back a few clicks. Okay. Have you discussed this in fundamentals? The gate control theory? Right. The gate control theory explains pain management, meaning you can interrupt pain at any step of the four mechanisms, meaning what are they again? Transduction, transmission, perception, and modulation. Okay, so you can interrupt pain at any point in time. So for instance, in transduction, so the transduction says it was the release of the chemicals, right? After you get an injury. So example is when you take NSAIDs, for instance. NSAIDs are prostaglandin inhibitors. Now, what is prostaglandin? Prostaglandin is a neurotransmitter for pain. So therefore, if you take NSAIDs, you prevent prostaglandin from being released. Will there ever be pain? No, because there's no pain chemicals. Okay, so nothing will be transmitted. Does that make sense? Okay, so how does this one, where did this one go? On the shin. So which step in the pain process is that under? Under modulation, correct? Right. So here comes the gate control theory. So the theory goes that anything unpleasant. So let's say you look getting a score of 32 on your exam, or let's say being rejected um, by somebody, okay, or having pain, or and something distasteful, okay, sadness, right? Anything unpleasant travel through fine nerve fibers, small nerve fibers. Whereas anything pleasant, let's say eating your favorite food, watching a concert, okay, going out on a date, uh, what else? Getting 100 on your quiz. What else? Getting married, okay? Having to see your firstborn, for instance, okay? Celebrating your birthday, anything pleasant travels through sex, okay? Travels through large nerve fibers. Now, which is easier to stimulate? Larger things or smaller things? How do you stimulate a tiny little piece of hair on your table? Whereas this table itself. Make sense? All right. So what you're doing is when you rub your shin, you are actually activating large nerve fibers. So when you do that, you effectively close the gate. So therefore, you're trying to compete. Which ones again? Which nerve fibers carry painful or unpleasant sensations? smaller nerve fibers, whereas bigger nerve fibers, something pleasant, right? Like that's why that's the objective or the whole point of massage. Okay, so if you ask massage therapy, why does a massage feel good? Because you are activating large nerve fibers. Okay, so therefore, if you activate large nerve fibers, then there's competition. So of course, which ones will travel faster? Sensations through larger or smaller nerve fibers? Larger nerve fibers. Okay, so that's the whole point. Meaning you can, that's also where distraction comes in. Okay, so if you distract somebody from the pain, let's say you have them, you perform tricks, for instance. Okay, or you do, your patient is in pain and you have nothing to give. Let's say the doctor didn't order anything. You can do a stand-up session. Okay, yeah, let's say Benjamin can tell the patient, okay, two Jews walk into a bar, right? And then the patient is distracted from that. So that is part of pain relief. Any question about the gate control theory? Another example is it should still be on YouTube. I watched this group of midwives who deliver at home. Midwives that deliver babies. Okay, so they practice a different type of technique with pain management. They Some of you may be offended, but it involves clitoral stimulation. The clitoris. Okay. So during the height of labor, because it's all natural, they don't use opioids. Okay. So it's all natural childbirth. So at the height of a contraction, when the woman's really in severe pain, they stimulate the clitoris. And if the husband is there, of course, they allow the husband to do it. The husband doesn't want to, then it'll be the midwife. Okay, because again, the same idea that if you stimulate large nerve fibers, it will close the gate, right? And they're still in practice. Okay, I just don't know if the videos are still on YouTube though, because of course there's some mature audience only. Okay, for that film. Anyway, so those are examples. Okay. Like I said, for the neuropathic pain, this is again a abnormal sensory pathway, meaning there's an abnormal interpretation of pain here. Not like nociceptive pain, wherein you have a painful source, you know exactly what's causing the pain, but in neuropathic, we don't know. Another example here is the pain in, have you heard of shingles? Have you seen someone with shingles? Okay, so that's another example. So those do not work. Those cannot be medicated with opioids. Opioids don't work for shingles pain. Okay, so you give them Lyrica, for instance. Although sometimes when the patient is in the hospital because of it, and they have a huge, a flare of the lesions, we do give opioids for short-term relief. Okay, but again, long-term relief, they don't benefit from opioids. They just get constipation from the opioids. Okay, let's go to assessment. So I will start since now we've completed the pain chapter. So now when we go to simulation, I will expect you to do a complete pain assessment from here on forward. Okay, so if you're just assessing one aspect of pain, then that's incomplete. Deduction, 5-point deduction on your simulation. Are we clear? All right. So what do you assess when your patient has any pain? What's the usual thing you ask? It's usually the pain level, right? But take note, it's only one aspect. This is only assessing what? The severity of the pain. Okay, so that is incomplete. Is it enough to just ask for the severity? How bad is it? Is that complete? Okay, so definitely it's not complete. Okay, So let's go to the um, full pain assessment. But before that, let's read chart 9-1. So this is for those, because I'm sure there are students here. There are some of you that just cannot accept the nurse's definition of pain yet. Okay, so look at chart 9-1. Read the title for me, Mr. Benitez. Okay, there will be patients that will test your patience, okay? Especially if they're repeat customers and you've seen them before for the same problem, right? And then you already know, oh, here comes this guy again, and then you're the nurse again. Okay. Thank you for reading the first two bullets, Elisa.
No.
Are we clear with the first two? Right? So if you're still having a problem accepting this, then maybe you're in the wrong profession, right? Because this is how nurses are obligated to treat all patients with pain. Are we clear? So set aside personal opinions. Yes, you can have your opinion, but not at the clinical area. You can talk about them outside. Okay? You can go vent to your friends or at the bar. Just don't use any names. All right? And again, pain is purely subjective, okay? Cannot be proved or disproved. Do not use vital signs as a proof of, look at your vital signs, they're all normal. You're bluffing, right? Or you're saying BS, okay? So you're not in pain. No, that's not true. You cannot prove or disprove pain. There is no such thing as evidence. Are we clear? Right, it's purely subjective. Next two, thank you, Lord Jean. Okay. So if you find in this you find yourself in that situation, then ask yourself, okay, why is it difficult to believe this patient? Right? And then remember the first two again. All right? Because there will be, let's say this patient is, let's say, take me for example, let's say I'm your patient, right? So I'm there for with no physical evidence of pain. I just tell you, okay, I got belly pain, okay? And I say like this, hey, Nurse Benitez, I'm in pain. Give me something for it. And then I'm on the phone, right? And I'm chatting with people. Yeah, yeah, right. And I'm also on my iPad playing a game, okay? Having a good time. Then I ask you again, hey, didn't I ask you for pain medicine? Good. Huh? So are you gonna ask why is it difficult to believe me? So I have no physical evidence of pain, do I? No, here I am having a good time. I don't seem to be in any discomfort. Yeah. So isn't that challenging? Isn't that testing your patience? Like this guy is too much. Right? This guy is something else. Okay. All you can do though is chart it. Okay. If you really have reservations, okay, you write down the observation. Okay. Play it. Patient is smiling, laughing on the phone, speaking to somebody and playing, let's say you can even specify, oh, they're playing, is everyone still, anybody still playing the Candy Crush? You know, like that. Yeah, you can describe that. You can document that on your charting, right? Yeah, if you really, that way you're venting, okay? You're venting in your notes. You have no one to talk to right now, go ahead, vent in your notes, okay? Are we clear? All right. Okay, here again, on the same topic of hard to believe. Okay, hard to believe patients. Thank you, Ms. Latouche. Accepting and responding.
Accepting and responding to the result in sick patients.
To an occasional patient who does not have pain.
Does not have pain or doing so help to ensure that everyone who does have pain receives appropriate care. Healthcare professionals do not have the right to
Deprive
any patient of appropriate assessment and treatment simply because they believe the patient is not being truthful. Pain is extremely personal experience manifested by each patient. It is important to carefully assess areas of pain when administering our medication.
Okay, thank you. All right, and then before I forget, please don't forget to reassess pain. Okay, so on Epic, which again, most of you will end up using Epic, whichever hospital you end up in. Reassessing pain will show up on your work list. So whenever you put a number on pain assessment of more than 0, if you put there 1 or any other number besides 0, it will generate 2 reassessment tasks. 30 minutes and then 1 hour after your charting. Does that make sense? Okay, it will generate automatically. So it forces you to chart, okay, document, reassess the pain. And funny thing is, it also appears whenever you give any pain medication, including Tylenol. So even if you gave Tylenol for a fever, it will generate a reassessment. Okay, so all you do is just click and then chart whenever it becomes due, right? Or then document, not given for pain. Okay, you document that you gave it for a fever, all right? Okay, let's go now to your comprehensive pain assessment. As I said, severity is only one aspect. First is location. Where is it? Please do not give the patient hints. Okay, so if they're having trouble finding words when we get to the description, do not put any descriptions in their mouth. Okay, do not give them suggestions like, does it burn? Is it dull? Is it aching? No, let them describe it, okay, in their own words. And then just find the closest description on your drop-down box. Okay, if there's none there and you're not very, let's say, eloquent, or you're not very, what's the term? Articulate in the words, then you just put it under other. Okay, and then because you can free text, okay, under other. So location and then intensity, like I said, this is only one aspect, intensity or severity. We have a separate chart for the different assessment tools to assess for the severity or intensity. So for intensity, one aspect is numeric rating scale. So that's what everybody uses, right? 0 to 10, how bad is it? There's a variations for that. We have Wong-Baker phases for smaller children, for instance, younger than 7, which are not very articulate yet about describing, assigning a number onto their pain. So you can use the Wong-Baker phases, and then the child will just point to the face. Face pain scale, this is a variation, still uses the face method, but then there's a number attached to that's a combination, numeric with Wong-Baker phases. Then there's a verbal descriptor. So the patient chooses words, okay, instead of a face, and there's a number attached to each word. Visual analog scale, similar. Next is the quality. So this is what I mean by do not put words into the patient's mouth. Okay, let them describe it on themselves. Remember, pain is very subjective, right? So let them describe it. Do not give suggestions, okay? Because what will you do if you're in pain and desperate for pain management? What will you say? Yeah, right? So therefore, is your pain assessment accurate? No, because you're the one describing it, not the patient. Are we clear? If the patient is desperate, they'll just say, it's just pain. Then write the verbatim, okay? Go under other, put it in quotation marks. I'm just in pain, okay? That's the description. Onset duration, okay, what is it constant or intermittent? Okay, does it start right away? How long does it last? And then aggravating or relieving. What makes it better? What makes it worse? Then the effect of, and these are questions, by the way, you have to answer on the drop down. So under pain assessment, it's literally long because it will ask you each one: location, characteristics, effects, aggravating, relieving factors. All of these will be on your drop down menu. Okay, and you can't proceed. This will show up as incomplete on your assessments. So your assessments will remain red unless you complete this. Once you complete it, then you'll turn green. Okay, so one aspect is incomplete, your assessment is incomplete. Then you'll get a love note from risk management, from QI, because they check charting, and all incomplete charting, you'll get a note. Then if it happens habitually, then you get a warning because you're paid, okay? You were paid completely. You're not short on pay. You were paid every hour. So are you expected to complete your assessment? Yes, because this is part of your job, okay, to complete your assessment. Are we clear? Yes. So let's go now to what about if the patient is unable to express, okay, nonverbal patient. So what can we do for them? Okay, we have different assessments for them, don't worry. Especially the elderly. Okay, so here they are. Okay, so for babies, okay, infants, for instance, we use the FLAC. Obviously, babies can't say or point to a picture, right? So we use FLAC. That stands for facial expression, leg movement, activity, crying, and consolability. Please do not use FLAC on a grown-ass person. All right, so let's say you have a patient, a grown adult who has autism. Not all autism patients are verbal. Okay, some of them are non-verbal, right? They just groan and moan and shout, right? They not all of them are verbal. My daughter, though thankfully, she's verbal, but when I assess her pain, she's not able to describe. Okay, she can't do that. She just says, hurt. She just and then points in, let's say, teeth, hurt. That's all. She cannot describe. Okay. But can I use FLAC for her? No, she's 16. FLAC is inappropriate, right? So I have to use a different pain assessment scale for her. Okay, so that's for infants and young children below 7. Pain NAD is for dementia patients. Okay, especially advanced dementia, because early dementia patients, they can still describe, okay, you can still talk to them, and they still make sense. But pain NAD, and we usually use this for most patients not really having dementia, but at least who are lethargic. Okay, so we use pain NAD as well. CPAP is for critical care patients. These are patients who are sedated on a mechanical ventilator. So we use CPAP. But these three have the same basic foundation. So FLAC, pain NAD, CPAP are all based on the FLAC. All right, because obviously these patients are nonverbal, correct? So therefore, we can only assess their activities. Okay. Now for pain NAD, this one, let me show you the tool because it's not described here. Just so you're familiar with the aspects, what you're looking for when it's used. Okay, so this is pain NAD. So you have here, so each item, let's say for breathing, 0 if breathing is normal, but if they have occasional labored breathing, noisy labored respirations, and so on, they assign a number. Okay, and of course you total that will be your pain score. Are we clear? So there's 5 aspects here. Highest score is 2. Okay, The highest score for each item is 2, so that can still total 10. You see it? Okay, so there are 5 items here: consolability, breathing, vocalization, facial expression, and mobility also. Right, and then last one is consolability. Okay, so that's PANAD. Again, like I said, it's all based on flat. Right, we just don't call them flat, obviously. I already mentioned reassessment. So whether or not you gave an intervention, because sometimes there's no intervention because the doctor, let's say, didn't give you anything. Or let's say your intervention was you simply reposition the patient. Okay, let's say you change the position or you allow them to rest or whatever comfort measure. You use massage, or let's say you patted them, for instance, or you use music. There's always going to be a reassessment. Okay, so what was the effect of your pharmacologic or non-pharmacologic intervention? So for reassessment, depends really what did you use. So typically, if it's PO or oral medication, the reassessment is 1 hour. If it's parenteral, doesn't matter whether sub-Q, IM, IV, the reassessment is always 15 or 30 minutes, depending on your facility, because they design the frequency. Okay, so for my facility, they use 30 minutes for parenteral. Yes, somebody had a question. You raise your hand. Okay, management now. So what are our interventions? So obviously, we have pharmacologic and non-pharmacologic. Let's just go down the list. First is pharmacologic. Now, please don't forget about non-pharmacologic also. You'll typically nurses only resort to non-pharmacologic once they run out of medications to give. Or let's say the medication is too soon to give, right? Now, don't be surprised also, like I said, nurses, yeah, we have a subjective definition of pain. Doctors, different story. Okay, so I've seen doctors' notes, and it's written on the plan also. Let's say I had a patient last week who was non-compliant with the therapy, meaning he doesn't want his dressings changed. And he's in there for sepsis because his wounds are infected. Yeah, the stage 4 pressure ulcers because he was paraplegic. But he was refusing them, even though we were medicating him. Medication, and then we asked him, okay, you had your pain medication 10 minutes ago. We should be able to do your wound care now. He says no. So the doctor said, okay, if the patient continues to be non-compliant, you will discontinue the opioids, right? And then change them to non-opioids, right? And it's documented. Okay, so again, different. I don't want to say anything. That's a different profession. Okay, but for nurses, we know what our definition is. Okay, I'm not going to comment for the medical field. Stated on the first 2 paragraphs is pain management must be approached in a multimodal means. Okay, multimodal approach, meaning you don't use only one approach, meaning you don't stick with just pharmacological. Okay, you should use both pharmacologic and non-pharmacologic. And if you do pharmacologic, it can also be varied. Okay, it can also involve more than one type of medication. Routes, we prefer the oral route because eventually will the patient go home? Yes, so we can't giving IM, sub-Q, or IV at home, can we? It has to be in oral form. Okay. Plus the least side effects would be oral. Yeah, of course, there will always be side effects no matter what. There will always be adverse effects. But the oral would be safest, okay, or the least harmful among all the routes. Don't worry also, okay? So let's say you really have a patient that's getting on your nerves. Okay, so we have judgment on the size of the needle. Okay, by that I mean, what's the range for the IM route? What needle gauges are the range for IM? It's 19 to 23, correct? So if a patient pisses me off, what do you think I'll use? The 23 or the 19? 19. Legally, I can use a 19, right? Because it's on the textbook, okay? I can use a 19. All right? So that's how, that will make you feel better too. Okay, so that's, okay, leave a smile on your face and then you can go on to with your day, okay? And then you also have, the thought that, oh, next time I can do the same, okay? Sorry, there's no 23s available. How come the other nurse? Oh, that was the last one. We haven't received any delivery yet. Of course, you have a straight face. Okay, so we've got the IV, which is preferred by most patients. Okay, so oral IV or IM sub-Q. Please take note, if you're not familiar with the drug yet, consult the drug book, okay? What routes they can safely be given, although it will appear on your MARDA. Sometimes the pharmacy will put it in. Well, the doctor really puts the order in, IM or IV. Okay. Right. For IV option, we also have what we call spinal blocks. So these are catheters, IV catheters inserted by the doctor to a nerve. That means they have a pump infusing the analgesic. It's usually an anesthetic. Okay, this is different from PCA. Okay, so this is spinal blocks uses anesthesia. So anesthetics are attached to a pump and they are infusing. Okay, and only doctors will insert these catheters. Dosing, the general rule is we start low and go slow. I repeat, we start low and go slow. This is because young patients, most adult patients under 65, okay, so 19 to 65 years old, or even pediatrics, 16, 14 year-old patients, they develop tolerance pretty quickly. What is tolerance? Okay, tolerance is defined as the patient now requires higher doses of something of a substance to achieve the same effect. Just like alcohol. Okay, so Isa, when you started drinking, how much did you require to get a buzz when you first started? When you were 7?
Okay. One shot.
Okay, Miss Latouche, when she was 6, she required 1 shot. Now you're 21. How much do you need now?
A bottle.
A whole bottle.
Yes.
Okay,
I wasn't drinking before.
a big bottle.
No, a small one, because I wasn't drinking before.
Okay, that's fine. We're on Latouche now, so you're okay. All right. So same thing. So why did you require a whole bottle versus just a shot glass? Okay, because you developed tolerance. Okay, you got used to it. Same exact thing here. So anything nice, we develop tolerance to. Okay, so anything, sex, alcohol, drugs, or food. Okay, we always develop tolerance the longer we use or take it. Okay, so it's just natural human reaction. So for that reason, we always start with the lowest dose possible. And we try to stay on the same dose as long as it relieves the patient's pain. Of course, once tolerance sets in, the doctor is forced to either increase the dose or increase the frequency, whichever one is better. Are we clear? We call that titration, okay? Although not all drugs will be titrated, doctor has to order specifically. Are we clear? Now, when we titrate up, can we also titrate down? Yes. If you can titrate up, titrate means you adjust the dose. If you can titrate up, of course, you can titrate down as well. Okay? It's only fair and appropriate. If the patient has a certain type of pain, let's say acute pain. So let's say a patient who just came out of surgery, is that acute pain? Yes, that's acute pain. So are they expected to be in pain?
Yeah.
So do you wait for them to be in pain, or are you going to anticipate it? Anticipate. Okay, so for those patients, we use a round-the-clock basis. This will also help with cancer patients. Okay, cancer patients also given a round-the-clock dosing regimen. Those who you expect to be in pain. Okay, so no need to let the patient suffer. Okay, so it's better to treat it round the clock. So here, for patients who report pain 12 hours or more during a 24-hour period. So better to treat them round the clock. And then, of course, you have breakthrough. Remember breakthrough pain? So if they have pain in between their usual pain episodes, then you give them another pain medication for the breakthrough pain. All right, let's discuss patient-controlled analgesia now, or PCA. Now, what is it? So let me describe. So the idea here is patient-controlled analgesia. Why? One at a time. Okay, so this puts that's why the name, patient-controlled analgesia. We put the control of the administration of the pain medicine on the patient rather than them waiting for the nurse to administer it. Okay. All right, so this is a PCA pump. Now, okay, so this pump on the screen, this is the Alaris series. This is a little bit weird. So this is if you use the Alaris, which is called CareFusion model, this is the central computer. This is not the pump. Okay. Remember our pump downstairs, we have small smart pumps, yeah? Okay, everything is in there. It's the pump, and then the computer is also on the same device. This one is different. So the Alaris series, CareFusion, so this is their central computer. You can attach unlimited number of modules to it, pump modules, meaning this central computer, you can attach one module. This is the actual pump. This one, the smaller device right here, is the actual pump. Now you can attach maybe 4 on the left side, another 4 on the right side. All right, you understand? Okay, so what are you looking at? This is now the PCA pump. This is the actual drug. Okay, it's in a big vial. The vial is about 50 ml containing opioids. So it can be hydromorphone, could be morphine, could be, although we don't use Demerol, but it could be meperidine, Demerol. And the pump delivers the drug. Now there's a key here. So if you're thinking, oh, I can just grab that. No, it's not easy to grab. You have to break the whole thing to grab it. Now there's a key. On each nursing unit, there's only one key, and it's locked up in the Omnicell or Pyxis, right? Meaning, in order to get the key, you have to log in. And all nurses have their own biometric sign-in. It's our finger. So who accessed it? Based on your finger. So you can't fake it unless I, took your fingerprint and then, used it to sign in. But I had to go through a lot of lengths to do that. Okay, so therefore, if it was your fingerprint used to open the dispensing machine and you took out, it's recorded that, oh, you took out the key, the only key to the PCA pump. We can have multiple PCA pumps. Let's say we have 12 PCA pumps on the floor, only one key, right? So after you use the key, of course, you have to return the key. Okay, again, what time was it taken out? What time was it put in? By who, right? So therefore, we have accountability. Who took the key? So if there's any discrepancy, we know exactly and what time did it occur. Okay, we can see there. Oh, Zibby was the last one who took it. Okay. So this is the medication. There's a key to open and put it in. So you also need the key to take it out and discard it. Are we clear? Meaning, let's say the patient goes home and this is still half full. You have to discard it properly. You need a witness. And this is the pump that controls it. This is the actual pump. And this is the computer. Okay. What are the settings on a PCA? Now, there's a basal rate. What is a basal rate? A basal rate is not given to all patients. A basal rate is optional. The doctor can order a basal rate. What does that stand for? Whether or not the patient presses the button, the patient receives the opioid anyway. Okay, a steady hour-by-hour infusion. Are we clear? Right, that's a basal rate. Again, not all patients will receive a basal rate. The doctor has that option to give it. Most PCA are literally PCA, meaning the patient will have a PCA dose. That's the first setting. What is the PCA dose? Well, the first setting is the basal, right? So the basal can be 0, but there's 0 on no basal rate. And then everybody gets a PCA dose. How much the PCA dose will be, doctor decides. Okay. All right, so again, the basal rate, and then the next dose will be the PCA dose. Next is there is a 15-minute lockout. So here's the basal rate. And there's a 15-minute lockout. It says here demand or lockout, but I haven't worked for a facility that has anything other than 15 minutes. So I guess universal practice is 15 minutes lockout. What does a lockout mean? The patient's free to press the button anytime they want, as many times as they want, but doesn't mean they will get a PCA dose, okay? Because it's programmed into the pump. Basal rate can be 0. PCA dose is what do they get? How much do they get when they press the button? That's the PCA dose. So let's say it's 1 milligram. When they press it now, they'll get 1. There's a 15-minute lockout, meaning for the next 15 minutes, they cannot get any more PCA dose. They'll have to wait another 15 minutes. Like I said, doesn't stop them from pressing the button. They can press it all they want. The pump will not give anything because you programmed a 15-minute lockout. Now, is that reasonable? Yes, because imagine if this patient will be pressing the button a million times, they'll get 15 million milligrams, right? Okay, so you see the reason, right? Okay, so there's a 15-minute lockout, and then there's also a limit, a 4-hour limit, meaning in a span of 4 hours, if the patient presses the button once every 15 minutes, they cannot exceed a certain dose, okay? Because for these patients, can this be dangerous? Yes, imagine if we have no control over this thing. Remember, imagine giving the patient power over a PCA, unsupervised. Is that dangerous? Yes. So therefore, we have to set safety limits. Okay, again, what are they? We have a basal rate. Again, not all patients will get it. Everybody gets what? A PCA dose. Everybody has a 15-minute lockout, and everybody has a 4-hour limit. Are we clear? So those are your 4 settings on the PCA pump. It's easy. Once you turn on the pump, it will literally ask you those things in order, okay, one by one. Basal rate, you put 0. PCA dose, what do you do? Okay, whatever the doctor ordered, that's what you enter into the pump. Now, the beauty of smart pumps now is you just scan the pump, scan the drug, and then the Epic will send the information to the pump. You don't even have to program it. Right? So the pump, the Epic, your MAR on Epic will wirelessly transmit the order already programmed on the pump. All you have to do is hit accept and it will run, and then it will chart that you started the PCA at that time. Okay, so we're making things safer, easier for nurses now. All right? Because can we make mistakes? Yes. Is this a dangerous mistake? Yes, this is a life-threatening mistake if you make a mistake. All right? So that's why we have smart pumps and we have smart devices, okay? And we have the, of course, the EHRs now, okay? All right, a few rules. Patient on PCAs must be attached to a pulse ox monitoring device continuously while on PCA. There's no exception. They have their oxygen saturation have to be monitored. Why? What's the first sign of an overdose? Respiratory depression. So what is the number 1 manifestation? Desaturation. Okay, because your respiratory rate drops below 10. So of course, what will happen to your oxygen levels? It will drop and your CO2 levels will rise. Make sense? Okay, so that's one rule. All PCA patients will have what? Continuous pulse ox monitoring device. Second, and it's in the form of a warning here. Okay, look at this paragraph. Who presses the button? Only the patient can press the button. What if they don't have a finger? They don't have hands. They're paraplegic. Can they get a PCA? Yes, they can. Now, the American Disabilities Act mandated that as much as possible, all patients with disabilities, you have to make accommodations for them. So the pharmaceutical device companies, medical device companies, including those that make pumps, devised other methods to activate the pump. So you don't really need a finger or a hand, or even have to activate the button with a hand. We have other methods of activating the device. So we have blow straws. Okay, some of them also have let's say, well, honestly, that's the only thing I'm familiar with, the blow straws. Okay, so you just blow into a straw, and that will either activate, one straw will activate the PCA, another straw to activate the call button. Say you want to call the nurse. Okay, so they have a series of straws. Okay. Cool, huh? All right. Can the family activate it for them? Hey, the wife, or can the nurse press it for them? It's the nurse. No, that defeats the purpose of a PCA. So what are requirements, therefore, before you can get a PCA? Do you need a finger? Do you need to be able to physically activate it with your hands? Not really. What does it say here? The only requirement is the patient knows how to use it. That's it. If you know how to use it, you can get a PCA. So can I give a PCA to someone with autism who is unconscious, who is demented? No. What's the only requirement? Cognitive ability to use it. Okay, that's it. Doesn't require that you have to be physically able to press the button. Are we clear? Okay, so don't deprive. Okay, you're a patient. Oh, poor patient. Sorry, you can't have it. Sorry, you're paraplegic. Can't. Oh, even paraplegic is only half. No, bad example. You're quadriplegic. You're paralyzed. You can't press the button. I can't press it for you. And you say that? No, don't embarrass yourself. Right? All right. Let's go to the medications. So 3 groups, and then we'll discuss the side effects, and then that's it. First group are non-opioids. Non-opioids are Tylenol. Tylenol is not an NSAID, first of all. Okay, so what are NSAIDs? Ibuprofen. Okay, so yeah, aspirin is included, although nobody uses aspirin for pain nowadays, right? Except if you're a boomer. Yeah, those are probably the only people left. Huh? Boomer generation. Oh, the retirees now,
Yeah.
age 65 years and older. Yeah, that's the generation that used aspirin for pain. All right, so non-opioids are for mild to moderate pain, also for inflammatory type of nature pain, like arthritis or anything inflammatory, okay, any swelling, okay, inflammatory in nature. Let's go to the side effects or adverse effects. Start with Tylenol. Tylenol is harmful to the what organ? The liver. Okay, so that's Tylenol, by the way, comes as Ofirmiv. Ofirmiv is IV Tylenol. Okay, it's gaining popularity. It's very effective in minor surgery patients. It's given 4 grams maximum IV. So that's 1 gram every 6 hours. So yeah, so that's total 4 grams, right? Yeah, 4 grams in 24 hours. So that's the maximum dose. So here we use it for C-section, minor surgeries. Okay. So that's IV. It's a 15-minute infusion. Okay, so it comes in 100 ml vial, bottle or vial. So therefore, what's the rate for Ofirmiv? If it's a 15-minute infusion, it comes in 100 ml vial. What's the rate? Natalie, how many mLs per hour? Anybody? Okay, I'll put that as a math question on your test. 15-minute infusion, 100 ml vial. Please take note, there are different formulations of NSAIDs, meaning it comes in PO, IV, also topical. So diclofenac is an example of a topical NSAID. Diclofenac is also called Voltaren. Maybe you're familiar with Voltaren. It's diclofenac. The only IV formulation of NSAIDs is ketorolac, brand name Toradol. So ketorolac is an IV form of NSAID. It's the only one that I know of. It's still an NSAID though, so therefore has the same side effects as all other NSAIDs. So here are your side effects. So we know Tylenol harmful to the liver. What about for the NSAIDs? NSAIDs have number 1, GI. Can cause GI ulcers or peptic ulcers. Next is kidney damage. So that's why here it says if a patient has to take NSAIDs for a long period of time, patient will be placed on a PPI or sometimes an H2 receptor blocker. That will help prevent ulcers. Cardiovascular risk. Now, it only causes cardiovascular risk if the patient already has a history of cardiac disorders. Okay, so if you don't have any history of cardiac disease, you're fine taking NSAIDs. You're still at risk for ulcers though, and from kidney damage. So here, so NSAIDs can destroy the kidney. This can cause chronic kidney disease, but if you try hard enough, take a lot of it at one time, you can go into AKI as well. That's about it. Any questions on NSAIDs and Tylenol? Very good. Let's go to opioids. Okay, so there are 2 groups of opioids. We got the true opioids, and we also have the, when I say true opioids, that means they are the mu receptor opioids, and then we have the non-mu opioids, okay, or also called mu agonists and agonist-antagonist opioids. Examples are, of course, your morphine is number 1. Hydromorphone is about 5 times at least stronger than morphine. So we don't use hydromorphone for opioid naive patients. What does that mean? Opioid naive versus opioid tolerant. What do those terms mean? You're naive if you're not used to opioids. Okay, you've never taken them or you sparingly use them. Is that clear? Okay, so if you've only taken opioids, let's say after childbirth, you're still considered naive. Okay, so opioid tolerant patients are those who are taking it on a regular basis, every single day or months at a time or years at a time. That applies to this drug. Okay, are we clear? Okay, otherwise you can get morphine, but hydromorphone exclusively given to opioid tolerant patients. If in the off chance that they are prescribed to opioid naive patients, please start with the lowest dose or contact the doctor to clarify the order. If you really want this, is this really your choice? Are we clear? Okay. And the drug book says that too. And your drug labels on the the hydromorphone, which is Dilaudid, will say that too. Are we clear? All right. Fentanyl, now this is different from the fentanyl you hear on the streets, okay? So this is pharmaceutical fentanyl, not the one that's synthetic. Are we clear? So fentanyl we do use in the ICU for patients who are intubated. Okay, so this is our opioid of choice. We have it dripping. That or morphine. And oxycodone has no IV form. Fentanyl also comes in a patch and IV as well. So the oral fentanyl you see on the street, that is not pharmaceutical grade because there is no oral fentanyl. Is that clear? Fentanyl only comes in IV or topical, a patch, a dermal patch, transdermal patch. Oxycodone, like I said, only oral form. So not all opioids have an IV form. Are we clear? Right, later we'll look at it when we get to equinalgesia. There are only 3 that you need to memorize. Okay, so these are the true mu opioids, right? All of them, of course, come from the opium family. They're just different formulations, okay, different strengths. Then we have the benefit of these true mu opioids is they have no analgesic ceiling. What does that mean? No analgesic ceiling. What does the ceiling prevent us from doing? That's the ceiling, right? What does that prevent us from doing? Going further than that, right? That's it. You're gonna go up only as high as the ceiling will allow you, correct? So therefore, it's a limit, correct? So these true MU opioids have no analgesic ceiling. I repeat, no analgesic ceiling. So do they have a limit? No. What does that mean? The doctor can increase the dose as safely as they can to achieve the desired result. All right? Meaning, don't be afraid to give it. If you're alarmed by the dose, let's say, oh, 10 milligrams, really, doctor? They have no analgesic ceiling. Okay, although that's rare though. We usually get to that dose when we're in end of life type of scenarios. Okay. The last time I gave 10 milligrams of morphine, the patient died 5 minutes later. And for years, I blamed myself until I understood what morphine does. And then I felt better. Right? But for the longest time, I kept it to myself. I believed that I killed that patient. No, I did not. It turns out. Because the more I understood the analgesic ceiling, then the more better I felt. Okay, so no, it wasn't, the patient needed it. Okay, and then these drugs do not have an opioid ceiling, an analgesic ceiling, sorry. Any drug taken for a long time, of course, will cause withdrawal symptoms. Withdrawal symptoms can set in also in short periods. So let's say even if, let's say, John Lee was only on morphine for 3 days, if you take it abruptly, she will experience withdrawal symptoms. What are those symptoms? Rhinitis, abdominal cramping, nausea, agitation, restlessness, right? Okay. So you don't have to be on opioids for years to experience withdrawal symptoms. Are we clear? Can be a few days or a few weeks. Antagonists, these are the antidotes. Okay, so we got, about naloxone, okay, Narcan. Okay, let's go now to the adverse effects of opioids. Before that, let's look at equinalgesia. Now, why do we need to know equinalgesia? Now, you're the nurse. You need to ensure the patient receives adequate pain management when they go home. This means that if you've been giving the patient a certain dose parenterally during their hospital stay, you must give them an equal dose in the oral form. Obviously, we can't send them home on IV, can we? No. So they have to be switched to the oral form. There's a chart, or maybe it's a table. It's a table, 9-3. So this is the equivalent of an IV dose to the oral dose. Okay, so there are only 3. Don't worry, you don't have much to memorize. So 1 is morphine. So 30 of morphine orally is equivalent to 10 parenterally. Next is hydromorphone, which is dilaudid. 7.5 oral is equivalent to 1.5 IV or IM. And then oxymorphone, 10 milligrams oral is equivalent to 1 milligram IV or IM. All right, only 3. All right, because the others don't have an equivalent. Does that make sense? Say fentanyl, is there oral fentanyl? Not in the hospital. In the streets, do we know how much that dose is? No, we don't know. Any question on equinalgesia? Alrighty, very good, children. Let's go to a few problems first before we go to adverse effects. A few problems are the following. We've got substance use disorder. This is the new term for addiction. We don't call it addiction anymore. We call it substance use disorder. There's physical dependence and then there's tolerance. Now, there's difference between the 3. Tolerance, we already talked about. We used an example about Miss Latouche's drinking problem. What is physical dependence? This is when you manifest withdrawal symptoms when we stop the opioid. Okay, so that's physical dependence. Is this the same as addiction or substance use disorder? No, this is not the same. This is simply the patient was taking the opioid for a certain amount of time for an obvious pain reason, but for some reason or another, they stop taking it, and then they therefore will go into withdrawal symptoms. I already showed you the manifestations earlier. Now, tolerance, again, the drinking problem of Ms. Latouche. Substance use disorder. Addiction is the former name, or addictive disease. Now, this is a complicated problem. Okay, this is a medical condition. It is treatable. This is not caused by a single factor. It's not caused by just, oh, because I was taking opioids and then therefore I became addicted. That's not the only reason. That's just one reason. Okay, so it's a complex problem influenced by genetic, psychosocial, and even environmental factors. Again, the act of taking opioids is not the sole reason for addiction. Is that clear? It's a combination of different factors. Okay, because of its complex nature, does it need treatment? Yes, it needs long-term treatment. Okay, inpatient long-term treatment. Are we clear? All right. So one way to treat addiction or substance use disorder is by using another opioid. Ironically, we can put you on methadone. Let's say you were using heroin, for instance. So to help you with your heroin addiction, we will give you methadone. So methadone is one frequently used. There are other drugs. We have Suboxone as well, but methadone is the most popular. Can substance use disorder patients go into physical withdrawal when they don't get the drugs? Yes. Okay. So therefore, is physical dependence present in substance use disorder? Yes. Is substance use disorder present in physical dependence? No, it's not. Okay. You can go into physical dependence even if you're in the hospital. Okay, so the nurse suddenly stopped giving you the drugs, or let's say the scenario is we've been giving you morphine. Okay, so let's say you had open heart surgery. So you stayed in the hospital for 4 days. You were pain-free. Why? Because we loaded you with morphine. Okay, we made sure you're comfortable. Okay, you had just had a huge incision. We cracked your sternum open. So we gave you morphine around the clock. Well, of course, you're pain-free. So when you go home, we give you a script, sir. This is the equivalent of what we've been giving you. Please fill it. Continue to take it until you see your doctor in a week. Okay? Most patients don't understand. They'll say, oh, why was I even given this script? I'm not in pain. Why were they not in pain? Because we were giving it around the clock. So now the patient thinks, I don't need it. They didn't fill it. What happens that first night they're at home? Not just that, they go into withdrawal. Okay, they have, you see those symptoms we talked about earlier? They go into this severe abdominal pain, this agitation, shaking, and restlessness, vomiting. Okay. What caused these symptoms? These are withdrawal symptoms. So you need to, if you're in this scenario, you're the one discharging the patient, please educate them, okay? Because again, that's typically when this happens because the patient doesn't understand why they have to continue the drug at home. Are we clear now? Because can they just stop right away? You have to slowly get off it, like steroids. We'll skip pseudo addiction. It's not really commonly diagnosed. Any question about opioid naive versus opioid tolerant? You're clear about this? Okay, so are you opioid naive or tolerant? Very good. Am I opioid naive or tolerant?
I don't know.
I'm naive. Okay. Honestly, I've never taken an opioid. I've taken muscle relaxants. I've never taken an opioid. Yeah, come to think about it. Yeah, even if I had tonsillectomy, they just gave me ice cream and NSAIDs. I like the ice cream better. We'll skip opioid-induced hyperalgesia. It's not really a common problem. Yes.
They use only opioid on.
No, that doesn't make sense if you use another medication for PCA. Yeah, because they're in severe pain. That's why we gave them PCA in the first place. I'll take you to the adverse effects. Please go to page 214 for the adverse effects. All right. Respiratory depression is the most serious of all of them. The most common is constipation, nausea, vomiting, pruritus. Pruritus is not the same as allergy, okay? Pruritus is itching. And it's not present in everybody, but let's say my wife, for instance, she got that one time she got opioid. She believes to this day she's allergic, but that was actually pruritus. Okay, and she's a lawyer, so you think she'll listen to a nurse? No. So she's convinced she's allergic to Percocet. Of all these, constipation never goes away. What I'm trying to say is the more opioid tolerant the patient becomes, the other manifestations go away. They no longer feel nauseous. They no longer feel sedated. There will no longer be hypotension. There will no longer be respiratory depression. Okay, the longer the patient takes or the more the patient becomes opioid tolerant. Do you understand what I'm saying? Opioid naive patients, however, of course, they will all have these. So one thing will stay in all patients, whether opioid tolerant or naive, is constipation. This will not go away. This will even get worse the longer you're taking opioids. Are we clear? So it's important to educate the patient because I personally don't know what constipation means. I've never been constipated a day of my life, but I'm familiar with diarrhea. Ask me anything about diarrhea, I can tell you. But constipation, I don't know how that feels. Maybe you can tell me? But I heard it's miserable, right? Now, you heard? You've heard?
Everybody was constipated once.
Don't talk about them. Okay? Just speak for yourself. Okay, all right. Okay, so it's important to educate the patient. Take proactively take stool softeners or laxative if needed. Okay, increase fiber, fluids, okay, activity, etc. Because it can be quite serious. Okay, when the patients get constipated and they're in the hospital, then it's still your problem. Okay, so now you have to give an enema. Okay, it's a mess. Okay. So causes delayed gastric emptying, hence the constipation. Okay, so that would be the one thing that will never go away. Again, I repeat, pruritus is an adverse effect of opioids, not an allergic reaction. Are we clear? Do we understand each other? Okay. Of course, if the patient manifests symptoms of an allergic reaction, that's different. That means, the patient already has hives, and in addition to the itching, they also have shortness of breath, then that's clearly an allergic reaction. All right. What's the antidote if you do find yourself in respiratory depression? Okay, so naloxone comes in what routes now? We have it in a spray now. And everybody, just so everybody's aware, it's free, right? don't need a prescription. Okay, so if you have friends who might be in, in trouble, so it's good to have it handy, right? So you can save a life. And don't say, oh, let them die. No, they need to be healed. Okay, they need help so that they can pay taxes, okay? Like the rest of us. You want to be the only one to pay taxes?
No.
No, everybody should pay taxes. Most of these information is redundant, so I won't. Okay, so let's go now to cholanalgesics. This is the last. These are again also called adjuvant, ADJUVANT, adjuvant analgesics. So these are not used for, meaning their classification on the drug book is not an analgesic, okay? It's either an antidepressant, seizure medication, right? Or anesthetics, okay? So they're designed not really for pain. And as stated here, this is often a trial and error. So the doctor will try one adjuvant versus another, okay, to see what helps with the patient's neuropathic pain. Give you an example. So I did a short stint as a home health nurse. So there was this one patient, she had a beautiful lanai. You know what a lanai is? Popular in Florida. It's like a sunroom. Okay. So you pull up to her driveway, that's the first thing you see. She's in the lanai, the sunroom. She was like this, had a perfect, very stern look on her face. So she got up like this on her walker and then did this. That's how she greeted me. So I came in, talked about it, did assessment. It's an $80 visit. So it's a good visit. It's there in less than an hour. So I went in, and then her first thing is she just went on and on because of the pain. Okay. I did her wound care. She had back surgery. Okay? She had a spinal fusion. It's common, okay, for these patients. So she's in pain, she's miserable. What happens when you're in pain? Constant pain, unrelieved pain. Can you sleep? Are you happy? Are you constipated? Yes. Okay. So she had all those. She was constipated. She had insomnia because of the pain. She's miserable. Okay. So I know the drill. Oh, okay. So here we got an unhappy patient. So I called the spinal surgeon. They reported to, tell them, oh, the incision's fine. Your patient just hasn't had any adequate pain relief. So I told the surgeon what the problem is, and then he gave me a bunch of orders. So he ordered Valium, he ordered Lyrica, and he ordered Ambien. Okay, so small doses. So prescription, and then and I told her, okay, yeah, I can call this in for you. She said, oh, please. Okay, so I called it in to because the doctor gives you their DEA number, that way, because the pharmacy will ask you for the doctor's DEA number. Okay. So I called it in, and then, okay, so next day I visited, different story, different scenario. She was all smiles. She was still in the sunroom. Okay, I went in, oh, please come in. Okay, please come in. Hey, have breakfast. Come have breakfast with me. Of course, I say, no, I have to go. Stop, sit down. She was always sit down, eat breakfast. So I hurriedly ate, I'm supposed to do that, but now what am I gonna do? Right? And then she was so happy. And then before I left, she just said, oh, and about yesterday? Sorry about yesterday. Okay. So she was able to sleep. Okay. So she's relaxed. She's no longer miserable. She had a good BM, right? So see the difference? Okay. Yesterday she was chewing me out. She was chewing everybody out. She was lucky she let me see her, okay, or change the dressing. You see the difference? Okay. So this is what I mean by pain is a miserable thing to have. Okay. So if you don't manage it, this is going to be the result. Okay. You have a very unhappy patient. So what is your duty? What if anything you learned here today? What should you do if your patient's in pain? well, not just medicate, but because remember, there's non-pharmacologic pain relief as well, right? Manage the pain. Are we clear? And then depending on what you gave, whether it was NSAIDs or opioids, then you know the side effects, monitor them for the side effects. That's it.